Hello, I'm Dr. Collins, and in this particular video we'll have a look at both at the hormones that are exclusively produced during pregnancy and at hormones that have increased expression during pregnancy. Now, pregnancy is a time of significant physiological change brought about by various hormones and their interplay with each other. Knowing about these hormones, not necessarily every minute detail we'll talk about, but having a general idea will allow you to appreciate the remarkable physiological adaptation a female body has to go through to bring about a new life. Also, understanding these hormones will help reveal the basis of some pregnancy-related complaints and hence why this is a very clinically relevant topic. So here is a list of the most important hormones that play a key role during pregnancy. These messengers, which is essentially what a hormone is, a chemical messenger, are made up of simple building blocks such as amino acids and lipids, but they work together to bring about complex global changes in the body. We're going to start with human chorionic gonadotropin, which is also commonly referred to as the beta-hCG. Now, the prefix beta simply refers to the quantitative measurement of the hCG in the bloodstream. In other words, hCG is the hormone itself and beta-hCG is the numerical measurement of hCG in the blood. Usually, however, hCG is only qualitatively measured in the urine, and that forms the basis of the pregnancy tests that we do at homes by paying on a dipstick. We don't actually worry about the numbers. As soon as the fertilized egg attaches itself to the uterine lining, it forms its roots in the form of placenta. The placenta then immediately starts secreting hCG, and hCG's key function in return is to maintain the corpus luteum. Now, we need to remember what corpus luteum is, because even though it is a temporary structure in the menstrual cycle, in the pregnancy it has a vital role in the early stages. So, let's remind ourselves about the ovarian cycle briefly and remember the key points of the ovarian cycle that will put corpus luteum into context in this particular topic. At the beginning of the follicular phase, some follicles in the ovaries starts maturing and one follicle ends up becoming more prominent and takes over, which contains the egg that will get released in the middle of the cycle during ovulation. Once the egg is released, the structure left behind from the follicle is known as the corpus luteum. During menstrual cycle, there is no hCG secreted to maintain the corpus luteum, so it shrinks and disappears by the end of the luteal phase with menstruation. However, if fertilization does occur and hCG does maintain the corpus luteum then goes on to secrete further key pregnancy hormones, namely the progesterone, the estrogen, and the relaxin, which we will come on to in a minute. Remember, the placenta at this stage is very primitive, so it heavily relies on the corpus luteum to produce these other key pregnancy hormones to get the show running. Before we move on from the hCG, let's see what happens to its levels throughout the pregnancy. So, we already covered that the hCG gets produced quite early on during pregnancy, and it increases very rapidly in the first few weeks. It peaks at around the 12th or the 13th week of gestation, in other words, at the end of the first trimester. And in terms of the pregnancy test, the plasma, the blood hCG, becomes detectable as early as 10 days after conception. On the other hand, the home pregnancy tests based on urine hCG, which are also becoming more and more sensitive as the time goes on, are currently only advised to be taken about a day after your first missed period. In terms of clinical significance, hCG is the very hormone that causes nausea and vomiting during pregnancy, which is also sometimes referred to as the morning sickness. This is a very common clinical complaint during the first trimester of the pregnancy. Evolutionarily, the morning sickness is nothing dangerous, but it is rather hypothesized to be a mechanism to keep the mother away from possible toxic foods or poisonous substances to ensure the preservation of the baby, that is much more prone to having developmental abnormalities in these early stages of the pregnancy. After the first trimester, the hCG levels start declining a bit, and then it is maintained at a stable level until the end of the pregnancy. The hCG maintains the corpus luteum, and the corpus luteum goes on to producing the three other key hormones in the early stages of pregnancy, namely the progesterone, the oestrogen, and the relaxin, for the first quarter of the pregnancy until the placenta is mature enough to take over. So, let's focus on the progesterone and estrogen first, two of the three hormones initially produced by the corpus luteum, then by the placenta. These two hormones, as you probably know, are very powerful hormones that also play key roles in bringing about monthly cycles, in other words, the menses, and much earlier on, during puberty, estrogen and progesterone are actually responsible for the development of secondary sexual characteristics of females, such as breast development. But what do these hormones do during pregnancy? It is impossible to account for all the functions of these two very strong hormones, but their key functions are quite important to be aware of. During pregnancy, the progesterone maintains the uterine lining, for example, by stimulating blood vessels to supply endometrium so that there is a suitable environment for the embryo to grow. It also reduces the contractility of the smooth muscles, and this prevents preterm labor. And furthermore, at very high levels, progesterone actually has a very interesting function. It suppresses the lactation. So at very high levels, we will come on to this in a bit more detail later on. Prolactin is the hormone that is responsible for milk production, but during pregnancy, the very high levels of progesterone actually suppresses the function of prolactin by binding to the receptors that prolactin would normally bind to on alveolar cells of the breast, and thus inhibits lactation during the gestation. And finally, progesterone suppresses the mother's fetal antigens to prevent rejection of the embryo. And if you like, this all a bit resembles to the action of the immune suppressants that a patient would be prescribed after an organ transplantation to prevent organ rejection. So some can argue that a fetus is the perfect parasite that can utilize these hormones to enable himself or herself to create the perfect environment to flourish. Estrogen, on the other hand, helps with the development of the baby's organs and the correct functioning of the placenta, all very crucial functions. And it has some overarching regulatory role. And along with progesterone, estrogen actually helps with the breast development and hence the bigger breasts during pregnancy. And the very high levels of progesterone and estrogen, although causes to all these magical adaptations that allow the pregnancy to come about, it comes with a price. So these are the very reasons, these hormones are the very reasons of the mood swings that can occur during pregnancy. And interestingly, estrogen also causes hyperpigmentation of the body by stimulating melanocytes, which results in darker areola around the nipples and a dark line which is called linea nigra. Normally it's called linea alba because it's not very visible, it's white. But during pregnancy it becomes darker, and it appears along the midline of the abdomen, of the tummy during pregnancy, and sometimes the pregnant ladies get worried about this. But not to worry, you can reassure your patients that this line does fade away slowly after delivery, and it's not a permanent change. So, what happens to the levels of estrogen and progesterone during pregnancy? As with hCG, they start increasing from the onset of pregnancy. However, the increase is much more gradual compared to the levels of the hCG. So the estrogen and progesterone takes off gradually, and hCG here for comparison. And estrogen and progesterone peaks at the end of the pregnancy. Next, as we mentioned earlier, the last hormone that is initially produced by the corpus luteum, and its production is later taken over by the placenta, is the relaxin. Relaxin, just like estrogen and progesterone, also exists without pregnancy during menstrual cycles, and as its name suggests, relaxin relaxes the uterine wall after ovulation in case a fertilization does occur. And if the fertilization does in fact occur, instead of declining, the levels of the relaxin increases, reaching its peak at the end of the first trimester. So overall, relaxin relaxes vital structures such as the uterine wall and the pelvis during pregnancy. And this consequently serves to prevent uterine contractions, to avoid premature labor. But again, all of this can come with a price during pregnancy, and relaxin is therefore the main hormone culpable of back pain and joint pains during pregnancy, which are very, very common clinical complaints during this time. This over-relaxation can sometimes cause more serious problems, for example, pubic symphysis dysfunction, which can make even walking and mobilizing hard and painful during pregnancy. Towards the end of the pregnancy, relaxin also plays a role in softening and lengthening of the cervix in preparation for the labor, and that final role can actually explain this small secondary peak in the relaxin levels close to the turn. Next, let's explore another key pregnancy hormone, namely human placental lactogen, or simply HPL, that is also exclusively produced by the placenta and only during pregnancy. HPL is sometimes referred to as the human chorionic somatotropin. It's quite a mouthful as well, and it is very similar both in structure and in function to the growth hormone. So HPL basically modifies the metabolic state of the mother, for example, by reducing the maternal insulin sensitivity or glucose utilization, so that there is more nutrition, more sugars available in the bloodstream for the baby's growth. Sometimes the insulin resistance may become so severe that this can lead to another possible pregnancy problem called the gestational diabetes, which is another common complication affecting around 10% of the pregnancies, peaking in the second or the third trimesters. In terms of expression, HPL is produced by the placenta as early as the second week of the pregnancy, and its levels continues to rise slowly throughout the pregnancy, just like estrogen or progesterone. And this increase in its level is sort of paralleling the needs of the baby, who will need more and more nutrition to grow. Last but not least, let's talk about the final two key pregnancy hormones, oxytocin and prolactin. Oxytocin and prolactin are both produced by the pituitary gland, though from different parts of the pituitary gland, And this might be a good point to stop and revise the hormones, remind ourselves of the hormones produced by the pituitary gland to put things into perspective. The pituitary gland, as part of the endocrine system, is a prolific topic that deserves its own video. However, it is important to recap this topic briefly now to ensure topics are put into perspective, and it is highlighted how various fields of medicine, in this case endocrinology and obstetrics, are interlinked and they very much heavily overlap. So, pituitary gland is a hard-working little gland that resembles a bin, hopefully clear from my drawing here, in the brain, and it is one of the key endocrine structures in the body that affects and or controls various metabolisms. And you can remember the hormones produced by the anterior part of the pituitary gland, with this mnemonic flat GP if it helps, F for FSH, L, LH, A for ACTH, T for TSH, G for growth hormone, and P for prolactin. And the latter hormone is the one that we are interested in terms of pregnancy. Posterior pituitary gland, on the other hand, is responsible from the production of two hormones, which are ADH, also known as vasopressin, and the female pregnancy hormone, oxytocin. And again, in this video, we're interested in oxytocin as well. So, oxytocin, a posterior pituitary gland product, is a key hormone that has an important function in bringing about the labor by stimulating powerful contractions that thins and dilates the cervix and pushes the baby out of the birth canal. Once the baby is born, it also helps push out the placenta, and all the while it also helps limit the blood loss during labor, so quite a useful hormone. Oxytocin is worth noting as a side note. It is not exclusively produced during pregnancy. It is thought to have some role in development and functioning of some organs, both in males and in non-pregnant females, as well during normal development. However, this role is not really well understood yet. In terms of the levels of oxytocin during pregnancy and during labor, oxytocin is relatively low in the first 2 trimesters and may show some variation. However, the consensus is that oxytocin levels rises massively during labor, and the rising oxytocin levels stimulates uterine contractions and trigger production of prostaglandins as well, which further increase contractions naturally. If, however, labor does not progress spontaneously, it doesn't happen on its own, and there are issues regarding its progression, oxytocin in the form of an IV drip or prostaglandins in the form of vaginal pessary can be given to induce and or to progress labor. So oxytocin has another very important medical application that is important to be aware of. Can also be used to manage postpartum hemorrhage if, unfortunately, for whatever reason it may be needed. So finally, prolactin, an anterior pituitary hormone, as we discussed earlier, is the main hormone responsible for milk production and breast enlargement. During pregnancy, as we mentioned earlier, progesterone suppresses the lactation. However, progesterone levels drop after labor, whereas the prolactin levels continue to remain high in breastfeeding mothers, and therefore milk production is no longer suppressed. If, however, mothers do not breastfeed regularly, prolactin levels do start declining after labor, and therefore milk production cessates if not utilized. Sheehan's syndrome is a rare medical condition that may occur during childbirth, secondary to excessive blood loss and hypotension. It is a very rare condition, however, it is worth mentioning here, as examiners like throwing it in sometimes as one of the multiple choice questions. Basically, what it is that the pituitary gland becomes damaged as a result of the excessive blood loss, and thus the hormones we discussed that are produced by the pituitary gland may all be affected. Typically, the exam question would talk about a postpartum hemorrhage and an inability of the mother to breastfeed as the initial presenting feature. Well done for your perseverance. If you're still with me, here is a summary table of all the pregnancy hormones we discussed without any animation for a second for your notes. Bear in mind this was not an exhaustive list of all pregnancy hormones and their roles, but rather a whistle-stop tour of the main ones and their interplay with each other, with an emphasis on the clinical complications of pregnancy. So in other words, the medically relevant bits that you need to know and hopefully can build upon. Hopefully it was useful. Thank you very much for watching. If you liked the video, please subscribe and like to enable more videos to be made. And you can find some multiple choice questions related to this particular video and to other videos on the link below from Collins Medical Concepts. Good luck!